So hello everybody, and really welcome to this session. And it's great to see everyone, and I don't know about you, but I have really been enjoying this conference, and huge thanks to ICN for everything that is going on. And thanks also to Tori Lairdal and Peter Johnson for inviting me to chair this incredible panel of women, and I was given the privilege of reading their CVs, and my goodness, I'm going to cut it down to 3 points each, because they're really exceptional, and there's been a lot on leadership, nursing leadership, and here we have 3 fantastic examples. So I'm going to start off with, right at the end, is Professor, note, there's going to be a theme running through this, Professor Jill White, and she is the Associate Director of Global Education at the International Council of Nursing. And she's been seconded from the Faculty of Nursing and Midwifery at the University of Sydney in Australia. And she has been a dean there for many, many years. So fantastic academic and clinical experience, and now in the international world and bringing great things. And we met last week at the World Health Assembly with Lord Nigel Crisp, really moving the political agenda forward. So great to have Jill on board. Secondly, we have Dr. another theme, Beverly Malone, who's the Chief Executive of the National League for Nursing in the US. Incredible group that have been going for many years, Beverly, understand. Now, Beverly, my goodness, is ranked 39th in the top 100 most influential people in healthcare. She won in 2016 the Florence Nightingale Award. She has been part of the Commonwealth Nurses, visited the World Health Assembly several times, worked in European Union also on nursing. And she has been the Deputy Assistant Secretary for Health in the US Department for Health and Human Services. So quite fantastic. Last but not least, we of course have Leslie Mancuso, who is the Chief Executive of JPIGO and the President of JPIGO. Leslie brings 40 years of frontline health worker experience in design and implementing, very importantly, low-cost and innovative solutions to education. And Leslie brings 25 years of experience with JPIGO and has developed the most wonderful relations with international donors and NGOs and countries and ministers and many of us, and that's why we're here. So just to kick off, we're here to talk about, pardon? And of course, a nurse. We all are. Yes. We all are. Yes. So, and the theme really is tremendous education. You know, all of them with masters, PhDs, chief executives, and professors and faculty leads. So fantastic way to become leaders. So I just wanted to be very clear about what we all mean by simulation in nursing, because I think we all think we know what it means. And then when I was asked to do this, I thought, oh yes. And then I thought, well, really, do I know what this is all about? So I want to just lift up here a paper that you're going to have available, written by Marianne Alexander, who's here in the audience and who will tell us a little bit more about this study. And this paper defines simulation as a technique, not a technology, which replaces or amplifies real experience with guided experiences that evoke or replicate aspects of the real world. So I think if we hold that, it's not a simple definition, but I think it's really excellent. And at WHO, where I'm from, it's really important because it's evidence-based. So before I ask 3 very brief questions to the panelists, I just want to say what it made me think of when I thought about simulation. And I'm Fran McConville, and I'm based at WHO for the last 4.5 years. I've spent most years before that working in Africa and Asia, so I'm very much a country-grounded person. But I just remember when I first saw a woman having an eclamptic fit when I was in Bangladesh in 1984. And my goodness, what a shock. I feel it now, actually. You walk into that room and there's a woman, her legs were tied to the bed, she was fitting, They'd stuffed cotton wool in her mouth. Nobody was caring for her. There was bright lights. People were shouting. There was panic. You knew she had very slim chances of surviving and that her baby was probably not going to survive. And you felt so powerless. I had worked in a regional centre in Oxford where all the people with high blood pressure and all the rest, huge clinical trial on methyl dopa and misoprostol was going on. And I, at that level, never saw an eclamptic fit. And my goodness, I wish I had known, had some simulation. And then there was the day when I was examining a woman in labour, and all of a sudden I thought, but this is a cephalic presentation. Why am I feeling the lips? It was very strong, and I thought, what's happened here? And then I asked my supervisor to help, and all of a sudden it was a cord prolapse at 3 centimetres dilated, and with seconds she was in theatre. It was very distressing for her and for me. We weren't ready to deal with it. And last but not least, immediately before I came to the rather beautiful gilded world of Geneva, I was in Somalia, and I was being prepared by the UN in case of kidnapping and explosions and all the rest. And we had a 3-day training course. In the first course, we went through everything. We did resuscitation and bandaging and more bandaging and then coffee and more bandaging. We had a good evening, came back the next morning, went through what happens when everything kicks off and thought, this is all a bit theoretical, went for coffee, were called outside, and immediately, down, down, the bullets started firing everywhere, people's legs were flying, and the simulation was extraordinary. And we were out there collecting bodies, having to keep our heads down, hiding behind the Land Rovers and all the rest of it, and actually bandaging people. And again, what an emotional experience. You feel you're really part of it. And then you debrief afterwards and think, what could we have done better? So at that point, I'm absolutely going to stop, but hand over to Jill. And the question I have for you, Jill, is, can you tell us why the ICN thought that simulation in education was such an important topic that you proposed this panel?
Well, thank you very much. And let me just apologise up front for the fact that clearly I'm not Frances Hughes. But I will do my best to ably represent our CEO. And in truth, I've had much more experience with simulation than Frances has, so I feel quite okay about being here. And I am actually in charge of global education for ICN, so I hope I'll have something reasonable to say. But in relation to that question, ICN takes simulation very, very seriously as an essential part of nursing education. And why do we do that? Because the reason we do that is because ICN is absolutely committed to a number of concepts, and I think they all fit simulation: safety, accessibility, equity, and nurses gaining confidence in their abilities. And those really critical things all come together when we think about simulation. The safety part, I think, is absolutely paramount. I know as a potential patient or as a mother of now no longer obviously small children, but the idea that someone would approach me or one of my family and try and do something to them in relation to their health for the very first time, never having practiced it before, terrifies me, quite frankly. And I've seen particularly, I have to say, young doctors approach patients in the emergency department when I worked as we were called in those days, CAS sister, trying to put drips in to very frightened, very, very sick patients. And they clearly had not had the advantage of working with any form of simulation to be able to both practice the technical skill, but put that together with their demeanour, their confidence and their being, and stop the shakes in many ways. In terms of the accessibility, and particularly these days when we've got such very short lengths of stay in hospital, if we don't have things like simulation, I am really worried about our nursing students seeing wound healing, for example. There are many, many examples I could use. But nurses see wounds when people come into the emergency department, they see wounds when people return from the theatre. But how these days do they see wound healing? How do they know when something's starting to go wrong? Simulation with the decreased length of stay is now really, really critical. And the last one I want to talk about, apart from confidence, because I think that's fairly obvious, is equity. These days, when we have large cohorts of students going through programs, it's very difficult to ensure that every student gets the opportunity to see and do all of the things that we would want them to see and do, and to see those things across a variety of ages and a variety of conditions. But with simulation, as an educator and actually as someone who used to chair our accreditation committee, I'm very reassured that we can know that when we graduate our students, they have had opportunities to practice all of the skills and put them together with their knowledge and their being to be able to work with patients. So I should probably stop there. I'll take the whole session because I'm pretty passionate about this topic.
I think there's lots of people in the room too, so we'll make sure there's time for discussion afterwards with these great speakers. So just turning to Beverly now. So my question to you is that the National League for Nursing in the US has been promoting simulation-based training recently. And can you tell us a bit more about this?
Well, I'm delighted to, and I appreciate my colleagues' comments because they flow very nicely into mine. We've been promoting it for more than 13 years, colleagues, so it's more than a little bit of time, but it's been in collaboration with our colleagues at Laerdal, and it has to do with missions that align. Their mission, helping save lives, our mission, promoting excellence in nursing education, to build a strong and diverse nursing workforce, to advance the health of the nation and the global community. And then one of our values is excellence, co-creating and implementing transformative strategies with daring ingenuity. So it makes sense that we would co-create products and services for nursing education. And I'm just going to give you some of those that we have co-created. One is CIRC, and its Simulation Innovation Resource Center. It's a web-based resource for nurse educators to learn how to effectively use simulation, promote and evaluate student learning. It includes a series of 15 courses. It's used by nurse educators throughout the world. Then there's Advancing Care Excellence, and we do that. It's from our Center for Excellence in the Care of Vulnerable Populations. It's an online, free, evidence-based teaching resource using simulation to enhance faculty expertise in the care of vulnerable populations. And so far, we have seniors, veterans, Alzheimer's, those who have Alzheimer's, disabilities, and coming pediatrics in the community. They're being used in English-speaking countries, and we have plans for translation. Another one is VSIM, Virtual Simulation for Nursing. Screen-based virtual simulation teaching strategy to help build confidence and clinical reasoning in preparation for practice. Built on a serious gaming development strategy. That means our 3-year-olds can use it. Used extensively throughout the US, early evidence suggesting improvement in clinical reasoning skills and prioritization. SESSIN, Simulation Education Solutions for Nursing, comprehensive program delivered by the NLN and Laerdal to help programs assess their current simulation programming status and set future goals. Incorporates 4 workshops delivered by the National League for Nursing. It's a model for faculty development in India, Europe, and a proposal for use in China. Another one, Accelerating to Practice, a program focusing on improving the transition of new nurses from education to practice. It's the onboarding whole issue. Includes novice nurses and preceptor development components. But I want to mention that it's not just new nurses that are onboarded. There are all types of nurses that could be onboarded. Our NLN colleagues presented it yesterday and received much endorsement for its need in Denmark, China, Canada, etc. Then there's leadership, and it's the final one, Madam Chair. Leadership development for simulation educators. We have a belief at the NLN that if you do not have leadership, you can go to every conference you want. If you're not able to take that back home and integrate it into the system that you're working with, that's leadership. It will not work. So leadership is a very important component. This leadership development is for simulation educators, or sim leaders. It began in 2010 and continues today. It leads best practice efforts in the use of simulations. We now have over 120 simulation leaders across the US and internationally in Australia, South Africa, Singapore, and Canada. And for those out there, please consider applying. Our website is nln.org. Thank you.
Wow. That was fantastic. Great. So really good to see Jill's points being, really put into practice and how you've done it in the US. Tremendous, absolutely tremendous. So now Leslie, Japigo, low resource settings, inexpensive, access to all, picking up on the equity and access, leadership and excellence. What Japigo is really known for. So over to you to tell us a bit more about that.
Sure. Well, I think you're going to think that we compared notes before, but we did not. So it's wonderful to be consistent. First, let me say that Japigo has been, as many of you know here in this room, a champion of simulation for many years. It dates back way before my taking over as president and CEO 15 years ago. You talked about what simulation is, and I think it's very important to reiterate that it's an evidence-based technique, and I agreed with the technique, that facilitates real learning and results in sustainability of improving performance for the long term. And that's what we've seen in Japigo. Japigo believes strongly, not only in simulation-based learning, but also coupling that with low-dose, high-frequency timing and dosage, so that we're incorporating it into all of our programs. Now, before I give a couple examples, let me just say that I wanted to recognize Tor Laerdal and Laerdal Global Health. Japigo has truly been honored. Our doctors, our nurses, our midwives have been honored to support the development of many of the simulation tools that Laerdal Global Health has, as well as the development of Helping Mothers Survive. Right now, Helping Mothers Survive alone has reached 53 low-resource countries around the world, including, I understand just today, Syria is going to be taking it on. So we're very proud of that relationship and very proud of and honored to be working with the whole team at Laerdal Global Health. Now, let me say that we use simulation in a variety of different ways. Certainly, I've had the exposure since I travel 80% of the time to see us using simulation with pre-service education. We see that students find simulation as an area to be safe in practice. They also are able to learn teamwork because quite often that's how you implement simulation. So they learn the art of teamwork and communication in that safe environment. They also are able to get direct feedback right at that same time during the demonstrations. And therefore, that confidence factor that you heard about before is so important, giving them the ability to have that clinical confidence before they go in and take care of a client. Now, the other piece that must happen when you're looking at implementing simulation in a pre-service setting is making sure that you're also supporting the faculty or the clinical mentors. They also need to be trained on running simulation and also need to be trained on how you debrief after simulation. So it's a process. It's not simply using the simulation. There's a whole process to it. Now, when we also work with a lot of practicing nurses, physicians, midwives, and so when I travel out to far reaches in countries, whether that be India or whether that be Ghana, I have seen us use simulation, particularly the ones that Laerdal Global Health has utilized, because we're using it at the setting that these nurses and health workers are working at, which is very important. And what What you need is these portable, durable, cost-effective simulation tools that can be used at the site with these clinicians so that they're using what they have within their own setting. So in conclusion, I would say that interactive, simulation-based education that engages the participant, that allows them to do hands-on practice, that allows them to get constructive feedback, and that has the right dosage and timing is really critical, and it's critical not only now, but to the future of learning. And it works, and we've seen it work in countries like Uganda and Ghana and Afghanistan and many others.
Thank you, Leslie. What an amazing summary. Absolutely fabulous. So, you know, just off the top of my head, listening to this, we have so many barriers to quality nursing and midwifery care. Barriers of this, barriers of that, not enough money for this, can't reach that. And here we have the most phenomenal, cost-effective, low-resource and high-resource setting solution. And just a month ago, in one country, 60% of nurses were asked, as they were sent off to provide maternal and newborn care in quite remote clinics, how many deliveries did you do before you went? 60% didn't even see a birth, because that's how hard it can be where there are tensions between nurses, doctors, midwives, trying to all get their hands on the woman and all the rest of it. And what a tremendous solution this would be to help countries like that to really to move this. So moving on, just to say we've had words like it's a process, tools at the site, safety, accessibility, equity, fantastic, wonderful collaboration and alignment with Lairdale, Jhpiego, and many others, and I think much more to come. Excellence, transforming, ingenuity, web-based, screen-based virtual. I got a bit lost on the gaming, I have to say. I'd have to have a 3-year-old help me on that one, but still. And sim leaders, and really improving performance, helping mothers survive. And really, this is all about quality of care and putting the patient, the woman, the baby, the elderly person, etc., you know, right there. And as you say, making us feel that others who are now qualifying will feel good. So thanks to all three of you for now. You're going to have lots of questions coming, I know that. But I just really would like to ask Mary-Ann Alexander, if you'd just like to step up here on the stage, who is author and researcher of this wonderful paper, just to tell us a little bit about the research side of it.
Sure, thank you very much. As many of you may know, in 2014, NCSBN, the National Council of State Boards of Nursing, published a landmark study in simulation where we examined the use of simulation in the undergraduate curriculum. 10 schools from across the country participated, and we looked at whether up to 50% simulation could be substituted in place of actual clinical experience. And we did it in all the pre-licensure nursing courses. And what we found was there were no differences between students that were randomized into a group that had almost 0% simulation, students that had 25% simulation, and students that had 50% simulation. It was almost amazing how exact they were in their outcomes in both clinical knowledge and actual didactic knowledge. And we had a lot of testing that we put them through, including the NCLEX, the licensure exam, and then we followed those students 6 months into practice. And again, their ratings from their supervisors were almost identical regardless of what group they were in. So, you know, the conclusion of that was that you could feasibly substitute simulation for clinical experience, up to 50% of it. But a concern arose after we did that study that schools might jump into that without adequate preparation. And the one thing that the study did was we had a lot of preparation for the schools and for the faculty, and we ensured that those were all everybody was doing the simulation according to a very specific protocol. So boards of nursing were concerned, faculty were concerned, and so what we did was we assembled a group of the leading experts in the country on simulation. And we said, given these data from other studies that are out there, what type of guidelines can we construct to give to regulators as well as faculty at schools so if they want to begin a simulation program, they have some guidance. So I have some copies of the guidelines here, which I'm happy to distribute, and I don't know if I don't have enough, they're also available at our booth. It's number 32 in the exhibit hall. But, and if you go online, the resources are listed, as well as checklists that faculty and the schools can use to ensure that you are initiating simulation and substituting it correctly and having students start out in a program on a really solid start.
Thank you. Thank you. And, you know, the power of evidence. Excellent. And to have that kind of research done in a high resource setting, but I think it's time we emulated that in some low resource settings. And your point about making sure the faculty are really well prepared. This isn't just, as you've all said, not just going to what we're going to do afterwards, but actually really knowing the process and how to do it really well. But how amazing, I mean, quite a controversial outcome that 50% could be done. So I think at this point, are we okay to let them fire some good questions at you all? Sure. This is your opportunity. So would anybody like to come up to the mic? You can come up here or stand there and ask some wonderful people some great questions, which I think will help your practice.
And so many nurses decided we'd better stay put. We'd better keep working right now. We can't afford to do that. At this point in time, everything is getting better. Not everything in the US is getting better. But in terms of the economy has gotten better. And as the economy has gotten better, there is a consideration that maybe this is the time to step away from our nursing post. And that's a big economic issue for us too. And I know the competency issue, that we may be able to actually have students finish their programs earlier with the wonderful work of our simulated settings. So all of those build into an economic package that is good for nursing, but even more importantly, it's good for the patient. It's good for the people that we will be serving.
Thanks, Beverly, for raising that tension around education. It's global. It's not limited, I don't think. Leslie, would you like to say?
I think, or maybe Jill, because do you want to do, because you were leaning in. So go ahead. I'll do it after Jill.
I completely agree with Beverly. The other additional economic consideration, as I see it too, as a dean, is for the student. Because the cost of getting to clinical, working in clinical, often working away from the base of the university. In Australia, we're a geographically very spread country, so we send our students out to rural prac, and they're paying for their rent in Sydney and they're paying for rent out somewhere else. And the concertinaing of some of that time makes such a difference, not only to the length of their program potentially, but certainly to the expense that they have to bear. So I think that there are multiple views in relation to the economics that it brings, economic advantage it brings.
So I'll just add that, as Jeff alluded to, we are looking, and as we always do, at the economic side of the work in which we do, because we're working in low-resource countries, and there's a lot of demands in the healthcare sector in those countries. And I would say that thus far, some of our data is showing that it is cost-effective. You know, in a lot of our countries now, ministers and others, and we're positive about this, are not wanting to do education in hotels and education in large large settings. They're looking at cost. They have to look at cost. And at the same time, it's good because we're able to move this training right where the health workers are in the setting, in their context. And so looking at cost effectiveness of any interventions we do is part of what JPIGO's doing. Thus far, we've been able to see that in Ghana and others, there's promising data that shows that it may be, in fact, very cost effective to do simulation. And if you combine that with the data we're seeing, in Ghana, in Uganda alone, we saw data. We worked with it was hundreds of, we trained hundreds, I would say 750 practitioners in 125 facilities. And we are saying, as a result of simulation activity and the work we did, decreases in stillbirth, decreases in newborn mortality, decreases in many other areas, C-sections, you name it. And when you see these percentages of decreases, combine that with economic reasons to do this for low-resource countries, it becomes very promising for countries to use. And that's why we're looking at those issues.
I am so impressed with that proposition. There's another proposition that I forgot to mention, and I mentioned it when I talked about acceleration to practice. And this is where we are onboarding new nurses. They're graduating from programs and they're being onboarded. In the U.S., we lose about a third, and I know in Europe, in the U.K., we lose about a third of those nurses the first year, which is about, in the U.S., $80,000 per nurse because you prepare them. So in terms of actually the acceleration to practice online program with coaching and debriefing, it means that we're saving dollars with preparing those nurses for the units, making sure they get a dosage of education of what they need in order to stay on board. And we're looking at putting that into practice this coming September. And we'll have more economic news and we're hoping that our nurse executives will see the value, and we know that they will. And that's going to be a big dollar saver.
Great. Thank you very much, Jeff. A really great question. And I just want to quote the director of the Partnership for Maternal, Newborn, Child and Adolescent Health at a meeting on quality of care and quality, equity and dignity at the World Health Assembly last week. And she said, if ministers of health are worried about the cost of improving quality of care, think about the cost of poor quality care.
Absolutely.
And I think that what you're saying is exactly
And
that.
I think that's the added element, economic element, which is the cost of medical error, the cost to the community of having someone off work or sick or, hopefully not dying, but that's a reality. So that economics absolutely has to be put into the picture.
Wonderful. More questions. Peter's going around with the microphone there. We have one on that side, Peter, also, some on this side. We're just going to have maybe 3 or 4 questions, and I think everyone's itching to get their hands on the simulation itself.
Good afternoon. I'm from Liberia, and I know that JPIGO is heavily into Liberia, working with the nursing and midwifery schools. We at the Board for Nursing and Midwifery have at least gotten the schools to equip their simulation labs with most of the things that they need for simulation. Our problem is that they don't use the simulation lab that much because they don't know how to transfer knowledge to students. Sure. So I was hoping that at least in all of the talks here that there will be some programs that like Liberia can benefit from somebody teaching the clinical instructors and preceptors how to do the simulation so that students can benefit from that. Thank you.
Thank you. Would you like to answer? Who'd like to pick that one up?
Well, I can pick that up because we do work in Liberia, and you are certainly standing next to one person, Peter Johnson, who leads our global learning department and is also our director of of nursing and midwifery. And let me just say that that's why I talked about the fact that, you know, it's like any learning tool. You know, a tool is a tool, but you need the whole package around it. And we've learned that in education for many, many years. So the simulation is part of the whole package of how we need to learn. And so I'm glad that you recognize, and I think it's true, I'm glad that you see that the faculty need to be updated and the clinical mentors need to be updated as to how to use simulation tools and how to do simulations and then debrief with simulations. So there are ways to do that. We have programs that we do that. We do that in every country that we use simulation in our programs. There is a faculty component and a learning component. So we have it for you. We can do that.
This is the National League for Nursing, the oldest nursing organization in the U.S. And we are dedicated to teaching faculty how to work with students. We develop faculty. That's what we do. And so simulation is a new tool, just like my colleague is saying, for how to work with students. But what we found is that if faculty are not comfortable, I think my colleague talked about a little fear and lack of confidence, but you were talking about students, but there's some fear and lack of confidence with faculty. That's the secret, everybody. And so one of the things that simulation does is give faculty that opportunity for them to get comfortable with using simulation. And those of us who are of a certain age, the whole virtual simulation is maybe a scary kind of topic also, but this is an opportunity for us to move into a new generation of how to share knowledge and information, of how to transfer that. And the programs that I listed to you, such as ACES, that is about training faculty. It's nothing but about making sure that faculty is up to date so that they can then in turn train students and educate students.
Yeah, I'd just like to comment, really to introduce another bit of a scary word to people who talk about simulation. There's low tech and high tech, but there's low fidelity and high fidelity. And sometimes those two terms get completely mixed up. The fidelity meaning how realistic it feels to the person who's engaged in the situation. And you can use incredibly low tech and have it feel incredibly realistic if it's it's set within a learning context. So there's a case study, there's a case story, the person has a name. I've seen some wonderful simulations with very, very low tech part-task trainers where you drape a real person and have a part-task trainer, you know, an arm or a leg or catheterisation or whatever, so that the student is also getting the sense of the reaction from the person, how frightened they are, you know, have they been spoken to? The fidelity then really doesn't depend on the level of technology. It depends on the way the faculty construct the learning experience. And I think that's absolutely essential. It's the key part to making it realistic, which is where the learning comes.
This is fascinating. Thanks to all of you, and great question from Liberia. I think we're going to have one more question, and then you can keep asking your questions. I know there's one, maybe Peter will squeeze a quick one in, but keep asking your questions afterwards to the panelists. Please go ahead.
Yeah, thank you very much for the brilliant presentations. I come from Ghana, so Jipaigo has been doing a very good job in Ghana and has adopted some midwifery schools. And so they're actually using this. But I want to find out, is there an existing certification process? So somebody can say that I go through that and I become an expert. I become a master trainer. In Ghana, I know that Jipaigo has trained some trainers. Yes, but I want to find out if there's any formal existing certification process for this. Thank you.
We'll start with Leslie and then go.
I'm going to turn that to Peter. Peter.
Well, I just wanted to say I promised folks that I did not pass the microphone to people that were going to talk about Jipaigo as a Jipaigo person. It just worked out that way. I think it's interesting people didn't talk at all, we didn't ask questions about assessment and the power that simulation has for assessing. And that does require people that are certified, that have the skills in order to be able to do that, to make sure that they are assessing along criteria that are directly related to knowledge and skills, clinical reasoning. And we are doing that. We are developing OSCEs and OSCE circuits and relating them, mapping them back to the essential competencies for nursing, for midwifery, for other health professions, laboratory, and Liberia. But we do need to cascade that out. We do need to build those strengths both in the clinical faculty and education programs, and we need to build that into the practicing folks that are, and the regulators that are responsible for maintaining essential competencies in the workforce. And we're available to do that. We'd love to partner with NLN and the tools that you have available to you. Of course, we're partnering with ICN. It's really all about partnership, I think, so that JPIGO, so others aren't out there saying, this is the best way, the JPIGO way to do it, or this is the way that ICN wants to have it done, but we're really conveying a cohesive message about what the evidence says the best way to do these things are.
Thanks, Peter. Very quickly
Sure.
to Beverly, because I know there's lots of hands
Sue.
going up now, but we need to keep moving.
Yeah, Sue is my
Good.
alter being. Thank you.
See?
We know.
Hi, I'm Sue Ferneris. I'm the Deputy Director for the Center for Innovation in Simulation and Technology at the NLN. And I did want to address that there is a certification exam for simulation educators. There are actually 2 certification exams, and they are offered through the Society for Simulation in Healthcare. It's an international simulation society that's interdisciplinary, spanning medicine, physical therapy, occupational therapy, nursing. And there are 2 types of exams. There's an exam for educators. It's called the CHSE, Certification for Healthcare in Simulation Education. And then there's CHSOS, which is in relationship to the certification for operators of simulators, so the more technical component. And there are varying levels of entry into that certification, but if you go on to the SSIH website, very detailed information. The Society for Simulation in Healthcare also has an accreditation body that accredits simulation centers around the world. So those are 2 resources. Mary Ann?
And I was going to note that these resources that she just told you about, that some of them are listed in the guidelines here as well. So you have access, and they're also on the NCSBN website.
And
Brilliant,
Jen
thanks.
Breed's over here from
One last question.
from my team, was part of the Uganda study that Leslie was citing, and we just wanted to give a little bit of specifics.
Actually, and I can be very quick. So my name is Jen Breeds. I work at the JPIGO Global Learning Office. But also, I was part of the study that you did. I was a clinical preceptor and teaching nursing students at Johns Hopkins School of Nursing, and I had a group randomized to the 30% clinical simulation group. And I remember this quite well, learning about simulation, being very well prepared. And one of the things that I remember 10 years ago when I started my career in nursing and transitioning from pre-service to in-service was it was valuable. I had SimMan in my learning classroom. But when I came to one area that I see the future of simulation going in and where I see excitement is the idea of, when we say these different cadres grabbing for women or grabbing for experiences, I wonder about ways that maybe these cadres and different interprofessional, we all perform together, right, on teams in the workplace and when we all get to the wards and the units. And are there ways that we can think about using simulation to be team-based, not just cadre-focused, and can we move towards that? Thank you.
Brilliant. So a team-based approach. Now, I'm going to stop it there because I think this is such a fantastic panel.
Fran, can I say one more thing?
Oh,
I just
Peter.
want to say that we're all interested in long-term outcomes,
Yes.
right?
Yes.
Performance outcomes. So Jen was named one of the 50 best nurses in Baltimore. So there you go.
More
The
leadership.
simulation worked.
Wonderful. Wonderful. So I have learned a huge amount, I have to say, in a very short amount of time. But I really want to thank Jill and Beverly and Leslie for really speaking up to this point and helping all of us to better understand it. And huge thanks to Tori Lairdale for organising this at the invitation of the ICM. And please, I think it's now time for you to go back and see the simulators and ask questions of this wonderful panel and talk amongst yourselves. So thank you very much, everybody.
Had like rooms where they were like gushing blood, pressure, and the rest is one of the creative ways of doing interdisciplinary classes.
Yeah, and Japigo doesn't work in the U.S. where we do all global health. We're usually working in service, so people that are already nurses and midwives and doctors. But the biggest barrier is usually not a nurse.
Definitely afraid. So are you? You say you're.
But then also I was working in international development.
Yeah, we should. The reason why, and I'm sorry,
As it becomes, as we receive global endorsement, put, everything is open source. And again, so you can get the flip charts, you can download.
Cross-cultural, definitely.
The baby starts mistaking this for the nipple and it starts licking. Yes. And it actively is suckling onto the cup.
The Vice President of Nursing for AWA.
Oh, wonderful. Welcome.
It's a pleasure
to see mothers survive, which complements the helping babies survive suite. We want this to be easily picked up in low resource settings, but also anywhere. And we have preeclampsia and eclampsia, which is our newest one we're showcasing here tonight. And
I want to talk about the B too. So we'll cover those two things. So the first thing I want to talk about, Elaine, was I noticed when you went into the room.
I studied it last night and I knew I was supposed to do it, but I think I was so focused on the fundus and the lockia.
So one of the things that we do when we're educating faculty about debriefing is that it isn't one of those rapid fire question periods where we just start asking the student, what did you do right and what did you do wrong? Done correctly, it's done in a very coached and mentored way. You're facilitating learning by coaching, you're supporting, you're encouraging, and that's what coaching and mentoring is all about. So